Thanks. Okay, so thanks again for asking me to be here. My next talk is on immunotherapy and maintenance therapy in metastatic colorectal cancer. So I think to begin with, we need to set some goals. So these are the goals of treatment for patients with metastatic colorectal cancer. Get good tumor response. You just don't want to stop there. You want to have a prolonged response. Of course, improved overall survival, and let's not forget preserved quality of life. So whether it's immunotherapy, chemotherapy, or whatever therapy that you're talking about in these diseases, these are the important things that you want to actually achieve. So let's start with the role of immunotherapy. Now, as was being discussed in the earlier talk and following that, there are many methods. The three important methods for testing MMR or MSI is immunohistochemistry, polymerase chain reaction, and more often these days, it's next generation sequencing that we use in order to test. The concordance between these three methods is extremely high, and to prove that the MSI is high with one method is adequate enough. You do not have to check again that the other method is also showing the same result. So the first question to ask is this: what about the prognosis of patients with MSI high? You know, we keep on saying that MSI high is good prognosis, but is that the case in patients with stage 4? The answer is no. The prognosis of microsatellite instability high varies with the stage of disease. In stage 2, it's good. In stage 3, it's equivocal. In stage 4, actually, patients with MSI high have poorer outcomes. That's clearly shown in this study here. These are patients with MSI high. These are patients who are MSI stable. Look at the progression-free survival in MSI high versus stable. MSI high is only 6.6 months compared to 11 months. Cetuximab is ineffective in patients with MSI high. One of the reasons might be that MSI high is typically more common in patients with right-sided tumors compared to left-sided tumors. So prognostically, it is bad. Can we improve the outcomes by increasing the intensity of chemotherapy? This is the TRIBE2 study. These are patients with MSI high. It doesn't make any difference just because you escalate the chemotherapy, because you see that the center point is lying straight bang on that center line here. So escalating the chemotherapy is not the answer to overcome the bad prognosis associated with high MSI status. So we need to try a totally different trick when you're looking at improving the prognosis for these tumors, and that is where immunotherapy comes in. These are patients treated with immune checkpoint inhibitors. This is colorectal cancer, non-colorectal cancer. So it's now a tissue agnostic approval, wherein in metastatic colorectal cancer, it's approved. This was the first approval that it got. It was approved in the second line and beyond for patients who are deficient MMR or MSI high, and that's where we typically used immune checkpoint inhibitors. But came this ASCO, and this Keynote 177 study was actually read out. These are patients who are treatment naive stage 4 MSI high or dMMR patients. It could be either tested at the local lab. You need not have a central lab to do the testing. 300 plus patients were randomized to Pembro or investigator's choice of chemotherapy. That could be FOLFOX, FOLFIRI, bevacizumab, or cetuximab. The primary endpoint was dual. It was progression-free survival and overall survival. So that is what was done. And crossover was allowed at progression on chemotherapy. Now, this is the patient disposition. As I mentioned earlier, you're more likely to have a right-sided tumor being MSI high compared to a left-sided tumor, 67 versus 30, 70 versus 27, which is what we would expect. This is the primary endpoint, which is progression-free survival. That was doubled for patients who took the immune checkpoint inhibitor compared to those who took chemotherapy. Now, very interesting to see, like in many other immune checkpoint inhibitor trials, you see that for the initial 6 months, patients who actually started on chemotherapy were doing better compared to patients who started on immune checkpoint inhibitors. The green curve is the immune checkpoint inhibitor curve, and the purple one is the chemotherapy one. So for the first 6 months, the curve is actually in favor of chemotherapy and not on immune checkpoint inhibitors. When you reach around 6 months, the curve seems to cross, and from then on, it is immune checkpoint inhibitor all the way. So there are patients who actually progress very early in the course of their disease or treatment, and we still don't have a clear answer as to who are these patients who are actually progressing. The overall response rate was 33% for chemotherapy. Now remember that generally for chemotherapy in this clinical setting, I'm not talking about MSI high, I'm talking about an unselected set of patients, is around 50 to 60%. While see that the response is quite low here, that is because the response that you get with immune checkpoint inhibitors the response that you get with chemotherapy for dMMR patients or MSI high patients is lower. We started by saying that the prognosis is poorer. This is the response to the immune checkpoint inhibitor, which is 43%. So it's 10% better. But when you come down and you look at the progressive disease, this is higher. 1/3 of patients who started on the immune checkpoint inhibitor progress compared to only 1 in 10 patients of chemotherapy. So that's why you see that initially the chemotherapy curve is better compared to the immune checkpoint inhibitor curve. Now, this is the forest plot, which is showing that there is one set which is not doing well with the immune checkpoint inhibitor, and that is the set of patients with K or NRAS mutant. Now, is there a specific reason? At least I don't know why they aren't doing that very well. But what is the performance of these sets of patients in the previously conducted immune checkpoint inhibitor trials? At least with just the PD-L1 or the PD-1 inhibitor here, numerically the response rate is better for the wild type compared to the mutant. Similarly, here again in the checkmate 142, the same is the case, 41 versus 27. But when you add EP, it seems to be, equaling off there. So what is the reason? Is this the group of patients who are progressing very early? I think we still don't have the answer. So that's a question that we need to answer progressively later. What about toxicity? As we would expect, immune checkpoint inhibitor toxicity was much better compared to chemotherapy. We spoke about pembro monotherapy, but what about the combination of nivo and ipi? We have a small 45 patient study where the response rate is much higher. And more importantly, the progressive disease rate is much lower. We said it's 29% for pembro alone. It's only 13% here. 43% for pembro alone compared to 69%. But this is not yet standard of care because you only have a small cohort of patients that has been tested with this particular combination. What are the unanswered questions in this clinical setting? Early progression, is it patients who have a high tumor burden who progress? This is something that we have seen in the other immune checkpoint inhibitor trials. Or is it because of the molecular characteristics of these patients? Are they all KRAS mutant? We don't know the answer to that question as of now. What about quality of life? We've seen that the toxicity data is in favor of the immune checkpoint inhibitor. But have we seen the quality of life data? Not as of yet. Are we likely to see the overall survival benefit? The answer is probably no, because nearly half of all patients on the chemotherapy arm have crossed over into the immune checkpoint inhibitor arm. So when there's nearly a 50% crossover, you are unlikely to really see an overall survival benefit there. So in my opinion, who is the right patient with metastatic colorectal cancer for first-line immune checkpoint inhibitor? It should be a patient who's got an MSI high or a deficient mismatch repair status, who does not have a high tumor load and a high symptom burden. So the lower the tumor load, the lower the symptom burden, that is typically the patient who should go on an immune checkpoint inhibitor, because there are situations where high tumor load, high symptom burden patients might actually end up progressing and we might lose them rather than being able to prolong their lives. So that's the typical candidate, in my opinion, for this strategy. What about maintenance strategies? Now, these are the various maintenance strategies that are available. You start with a chemotherapy, just continue the same chemotherapy. You can have an intermittent strategy wherein it can be a stop and go, wherein you start with some chemo, stop that chemo and reintroduce that at the time of progression. Or you can start with induction and then cut down on the chemotherapy intensity and do maintenance, and reintroduce the same chemotherapy again when patients actually progress. So all of these strategies can come under the classification of maintenance therapies. So let's quickly answer the more important questions in this strategy. The first question is Optimox 1, wherein patients were either taking FOLFOX4 continuously or they were on FOLFOX7 for 6 cycles, maintenance 5 with leucovorin, and then got the FOLFOX7 again when they progressed. Now, when they looked at the results, there was clear evidence that cutting down to 5-FU does not compromise the progression-free survival here. So you don't have to continue the same chemotherapy endlessly because it does not benefit. Question number 2 was answered by the Optimox 2 study. Now, instead of 5-FU leucovorin maintenance here, what happens if you stop and then go ahead with chemotherapy at the time of progression? Now, there's clear evidence from the Optimox 2 study that if you stop completely and then restart, there is a negative outcome on the progression-free survival and the disease control. So stopping is not advisable. Continuing some treatment is better than stopping. What about when you're using bevacizumab? So again, this CARO3 study randomized patients after 6 cycles of Capox-Bev to either observation or just continue the capecitabine and bevacizumab. Continuing the combination of 2 clearly showed improvements in progression-free survival and to time to tumor progression 1 and 2 with preserved quality of life. So if your patient is on Bev, then continuing the CAPE with Bev or continuing 5-FU leucovorin with Bev gives you better outcomes compared to just observation. Same again, what about 5-FU plus Bev versus pause? Clear evidence to say that 5-FU plus Bev is better than pausing all the treatment. So whether it's just 5-FU capecitabine or a combination of 5-FU CAPE plus Bev, it seems to be that at least in terms of the progression-free survival, it is better to continue the maintenance rather than completely stop it. Do we have a benefit in terms of overall survival with maintenance? The answer is no. Do we clearly know that 5-FU alone should be enough compared to doing 5-FU plus Bev? Again, we clearly don't know the answer to that question. And that is the reason why this very nice algorithm published very recently as part of a meta-analysis in the JAMA clearly tells you that for patients who are having stable disease or a response after 16 weeks of blood plus chemotherapy can opt for observation or continue either fluoropyrimidine monotherapy or a combination of fluoropyrimidine plus bevacizumab. And at progression, you go back and start the same. So maintenance is better than not. 5-FU or a combination or 5-FU plus Bev are good options. We don't have clear evidence to say that the overall survival is prolonged. What about the use of anti-EGFR antibodies? We are talking about cetuximab and panitumumab. Remember that these are not easy drugs to tolerate. The skin rashes that you get with these drugs can be actually terrible. So unless we have reasonable evidence that benefits maintenance treatment, it becomes difficult to convince our patients to continue either of these treatments as maintenance. So the macro study is a phase 2 randomized study where patients, after a particular set of treatment with FOLFOX plus cetuximab, were randomized to either cetuximab plus the whole chemotherapy altogether or not. So what did this trial actually show us? The trial actually showed that for patients who had wild type RAS, there is a benefit to continuing cetuximab beyond your induction therapy there. So there is some benefit in an unplanned subset analysis of a phase 2 study. What about panitumumab? That's what was looked at in the Valentino study. Again, a small 220 patient study. Patients took FOLFOX plus panitumumab, or both arms started with FOLFOX and panitumumab, and then they were randomized to 5-FU plus panitumumab or panitumumab alone. A combination of these two was better than panitumumab alone in terms of progression-free survival again. So what about conclusions as far as anti-EGFR maintenance in metastatic colorectal cancer is concerned? We are talking about wild-type patients, wild-type RAS and RAF patients. The data for anti-EGFR maintenance is not strong, because this is based on subset analysis in phase 2 studies, at least the macro study. Cetuximab alone or a combination of 5-FU plus panitumumab are choices for treatment if you decide to do maintenance. Please remember again here that we don't have overall survival benefit clearly proven. We also don't have this strategy compared to 5-FU alone. I think 5-FU alone must be an equally good strategy in this clinical setting. So we don't have the data to say that an anti-EGFR maintenance is better than 5-FU alone in this clinical setting. For me, quality of life is a major concern for these set of patients. So the summary for maintenance is that the ideal maintenance should be individualized. Patients who have lots of tumor load but are tolerating the treatment, have got a partial response or stable disease, should be discussed for maintenance. Patients who have very little tumor load, have had a great response, are not tolerating treatment well, very minimally symptomatic or asymptomatic, should not be considered for maintenance. That's my take on this issue. And that's primarily because all this data is based on just PFS benefits, not overall survival benefit. Observation remains an option for those with low volume disease and indolent disease. Please remember that patient preferences, cost of care, and toxicities are extremely important to consider when you're doing maintenance strategy. Thank you so much again, and have a good day. We will take questions if there are any at this point in time. Thank you so much, and I hand it over back.
Thank you. Thank you, Dr. Senthil Rajappa. Shamir, whether the questions are ready? Yes.
So what is the indicator of restart? Is it CEA symptom or radiological progression? So it should be radiological progression. Whenever there is a symptom, we obviously would go and do radiology. And if there is progression, get back to your old chemotherapy. So it's not based on CEA.
So let me supplement of this question. If a patient treated for colon cancer and in his follow-up, only the CEA marker, we have seen that it is rising. So it is progressively rising, and a PET CT scan, all the radiological modalities came with negative. So in this context, what you will do?
I will not treat this patient, especially if he or she is asymptomatic. We have frequently, I wouldn't say frequently, we have found that when this kind of a thing is happening, most of the time the relapse is in the peritoneum, which is not typically picked up by all of your modalities that we have as of now. If patients are asymptomatic, I would prefer not to treat. If they are symptomatic for peritoneal disease, even in the absence of radiology, I tend to treat sometimes. So that's the way I look at this. But just rise in the CEA, I wouldn't treat.
Thank you, sir.
I'm sorry to interrupt. I'm muting everyone. Only the co-host can be unmuted myself.
Okay.
So, Dr. Senthil, with Dr. Mustafa, if the patient is having and also losing some weight, same patient, CA rising, losing weight, but no radiology. Cannot hear.
Yeah, in that situation, if I've ruled out all other causes of weight loss, then the option would be either to start treatment straight away or do a laparoscopy just to make sure that that's what it is and it is disease in the peritoneum before we decide to start on some therapy. That's what I would do in that situation.
Suman, we go for the case discussion then.
Yes. Now it's time for the case discussion. The session will be moderated by Dr. Senthil Rajappa. And the panel of experts will be Professor Alessio Morganti. Sir, are you there? Professor Alessio Morganti, sir, are you there?
Yes. Yeah.
Yeah, okay, sir. And Dr. Dr. Abhishek Bansal, are you here?
Abhishek is here. Abhishek.
Sir, you need to unmute. Abhishek, sir.
Dr. Abhishek, can you hear me? Okay, let me check. Dr. Sunil Pasricha.
Yeah, I'm here. Yeah, good afternoon.
Okay, sir. He is a senior pathologist, senior consultant of Rajiv Gandhi Institute. And Abhishek Bansal, he will supposed to join within a time. He is the senior consultant of radiology and imaging, Rajiv Gandhi Institute. And from Sumit Goel, already we have we have heard his presentation. Dr. Sumit Goel, medical oncologist, Rajiv Gandhi Institute. So over to you, Dr. Senthil Rajappa.
Sure. Thank you so much. I actually have a case with metastatic colon cancer, which I have now converted to a patient with rectal cancer because I want to involve Dr. Alessio also in this discussion. I would have loved to have a case of locally advanced rectal cancer, but unfortunately I don't have because the panel was supposed to be on metastatic colorectal cancer. Never mind, we'll bring everybody in to look at what's the best way to manage this particular 52-year-old lady who actually came to the outpatient with easy fatigability and abdominal discomfort of 2 months, bleeding per rectum, constipation, passes motion once in 3 days. This is in spite of plenty of laxative that she takes. A rectal examination showed a growth mid and lower 1/3 of rectum. They tried doing a colonoscopy, which showed an ulceroproliferative growth in the rectum, mid and lower 1/3, extending up to the 10 centimeter mark. Scope was not negotiable. They couldn't get beyond the growth. The blood values are normal. The CA was 117. The ultrasound actually showed liver metastasis. The CA 19-9 and AFP were normal. A PET CT scan was done for this lady. Please forgive me, that's supposed to be a sigmoid colon, but for the discussion's sake, we have gone down to it being a rectal growth. So the liver is studded with metastasis, as you see in all of these PET CT scan films that you are doing here. The biopsy came out to be a moderately differentiated adenocarcinoma. So let me ask Dr. Pasricha, would you add anything else in terms of the pathology report in a patient like this? Or you are happy when, you are happy to call it moderately differentiated adenocarcinoma?
Since it's already a metastatic disease, so I think the prognostic histopathological features are not going to be much help, like tumor budding, LV emboli and all that. So I think the molecular tests will be more informative in this setting.
Right. So what molecular test do you routinely do at Rajiv Gandhi, Dr. Pasricha? Is it reflex testing or the clinician has to actually request, and what do they actually do? Okay. So the upfront testing, what we are doing is that for it's our institutional policy that as per the NCCN 2019 recommendation, we are doing MSI by immunohistochemistry for all the cases upfront. It's a part of our histopathology report. And regarding molecular testing, yes, we get the requisition from Dr. Sumit. And we are doing KRAS, NRAS, extended panel, looking for the 6 codons. On the most commonly, it is on the exon 2. 12 and 13 codons are involved. And we are doing NRAS also because for anti-EGFR therapy, even the patients with the NRAS mutant, the therapy is not going to be so effective, although it constitutes around 5% of the cases, NRAS. What about BRAF, Dr. Pasricha? You would do that, or Sumit would request it and then it is done?
BRAF, there is a persuasive evidence that the patient with the BRAF mutation, that they constitute around 10 to 15% of the cases which do not respond to anti-EGFR therapy. But as of now, there is not a very strict recommendation that with the for a BRAF testing to predict the responsiveness of the anti-EGFR therapy.
Okay, so let me quickly summarize that part for our listeners. As was rightly pointed out by Dr. Pasricha, beyond saying that it's a adenocarcinoma plus minus the differentiation that you would give, there is no additional prognostic value added to the other markers in patients with stage 4 disease. The molecular testing that we will routinely ask for is, as was rightly pointed out, KRAS, NRAS, extended panel, so that you're looking at all the possible mutations. MSI or MMR, whichever you like to do, whatever method you like to do, you need to do one of those tests for sure. We would do BRAF also routinely now for two reasons. One is the lack of effectiveness of anti-EGFR therapy, and also because for patients who can get their hands on, we now have BRAF or anti-BRAF strategies with TKIs and anti-EGFR antibodies combined. So that would be our least molecular panel that we would do for all of our patients with metastatic colorectal cancer. There are people who will add on HER2 by either NGS ERBB2 amplification, or they would do IHC for HER2. One of these also, because at some point in time, it may be worthwhile looking at those therapies. So that's what we routinely do. Sumit, you want to add something to the list that I have made, or you're happy with that list? Sumit's connection seems to be a little unstable. So that's what we would do. Dr. Alessio, let me bring you in at this point in time. Would you consider palliative radiotherapy to the rectum? Because this patient passes motion once every 3 days, and then there is some bleeding, though the hemoglobin is still normal. How would you handle these obstructive symptoms in a patient who's presenting with stage 4 disease? Professor Alessio.
Yeah, I would consider palliative radiotherapy. The patient is symptomatic. We can help the patient very simply. I was using for some long time the short course regimen, but defining as a target only the macroscopic tumor, okay, not pelvic lymph nodes, prophylactic treatment of the pelvis. And in these patients treated with palliative radiotherapy and then systemic therapy, sometimes we had very, very long local control of the disease. Actually, I'm using a 2-day regimen, 4 fractions in 2 days, and this is very, very good. And it's not toxic because the dose is not so high, it's only 20 gray, but 20 gray in 2 days are very effective in terms of palliation.
Very good. So that's a very important clinical tip, so that you want to complete your palliative radiotherapy as quickly as possible and get to the chemotherapy, which is important for systemic control. So as Professor is saying, 2 days of radiotherapy, 4 fractions seems to be a super idea to get our patients through the radiotherapy quickly and then get on with the systemic therapy. Thank you so much for that, Professor Alessio. Sumit is here, I believe. Sumit, do you do DPD polymorphisms in your patients who are going on 5-FU infusion, Sumit?
So we are not doing as a routine as of now. In last 5 years, we have tested about 7 or 8 patients, out of which 5 had come positive, sir. But
okay.
That was only once they had shown us the symptoms. And most of these patients were from Nepal, sir.
Okay. So routinely we are not doing, so are we. But I think there is some recommendation from the ESMO of late that it might be worthwhile doing the DPD polymorphisms. The problem with doing that is the polymorphisms might also vary depending on your ethnicity, and you're rightly pointing out that issue, Sumit. that Nepalis seem
Yes.
to be having a higher incidence of these polymorphisms compared to our own population. So unless you are clear about what polymorphisms you're looking for, you might actually miss some and the test might become wasteful. So routinely, I don't do it, but it's something that the recommendations have started looking off of late. So Sumit, what is your first line chemotherapy and targeted therapy for this patient with rectal cancer, multiple liver metastasis, and of course, stage 4 disease, is symptomatic only for the rectal area? Professor Alessio has already given radiotherapy for 2 days to palliate those symptoms down there. So what would you do next?
So she is 62. Comorbidities are not there.
Yes.
And sir, mutational status, sir, molecular
KRAS mutant. KRAS mutant.
Mutant is there. KRAS mutant.
Yes.
And high status, sir, though it is likely to be since she is mutant.
Oh, I didn't hear you, Sumit. I can't hear you. Come again.
The MSI status.
MSI is stable.
Okay. So I would like to go for chemotherapy, sir. Since she is not having any comorbidities, maybe FOLFOX with bevacizumab.
FOLFOX with bevacizumab is a very acceptable. I have 2 questions for you, Sumit. One is, if the MSI was high in a patient with large tumor burden like this and the KRAS being mutant, would you be tempted to go on immune checkpoint, or would you still say, I want to do some form of chemotherapy?
I will still would like to go with chemotherapy with the biologicals, sir.
Great. So that's probably the appropriate thing to do, because there were patients who progressed very early in the Keynote 177 study, and at least from the forest plot, though only about 20% of patients were mutant for KRAS or NRAS, it looked like as if those patients don't benefit from the immune checkpoint inhibitors. So somebody who's got large tumor burden like this and is mutant KRAS, I would be very, very hesitant to put this patient on a first-line immune checkpoint inhibitor therapy. So I agree very much with Sumit. Sumit, the other question that will come up is looking at the liver. I don't know if Dr. Abhishek is around. Dr. Abhishek, are you around?
Yeah, Abhishek is here.
Dr. Abhishek, can I ask you, these are bilobal liver metastasis, large volume disease. Do you think at any point in time in your experience, a patient like this has gone on to get liver resected at some point in time, Abhishek? I don't know. I think somebody has to unmute him or inform him. I don't think he is.
Sir, if I may answer for him.
Yes, sir. Please, Smith.
Sir, with this disease burden, our surgeons definitely are not going to operate on him, sir. They are very judicious in their approach. But at some point of time, a response is there and liver predominant disease is there, sir. And then our intervention radiologists, sometimes they do go for liver-directed therapy, sir.
Great. So, Sumit, my question to you again is, large volume, you're talking about liver-directed therapy. Would there be a benefit to doing a triplet in a situation like this? Instead of doing FOLFOX, would it be good to do TRIBE?
Yeah, TRIBE to FOLFOX ZIRI plus that. Yes, we can do that, sir.
The moment we say a triplet, you get tired. I can understand that, Sumit. It's not easy to do it. There is a survival benefit there. Yes, but very important is that it's not for everybody. It's somebody who is very fit, young. 62 can be called young in colorectal parlance, but it's very important to make sure that that patient can actually tolerate a triplet, because triplet plus bevacizumab has shown better responses, especially if you're talking about liver-limited disease only. And then considering for some liver-directed therapy at a later point in time, of course, doing surgery for the rectum also. So you need to make a very careful choice. Judicious is the right word, as Sumit said. Sumit, you wanted to say something?
Yes, sir. I wanted to say another point, sir, which I feel is important in triplet is social support, sir.
Very, very important. You have to be sensitive to all of those. Professor Alessio, what do your medical oncologists do? Are they very aggressive with large burden disease like this, or they would be gentle and say, look, this is not going to get to surgery at any point in time at all, so let me be as gentle as possible? What would your medical oncology strategy be, Professor Alessio?
medical oncology strategy.
What would you, because, what is it that goes on in your tumor board when somebody shows a patient like this?
If they show me a patient like this is not a patient for me.
That's obvious.
So treat this patient, and in the case after chemotherapy, after systemic therapy, the metastatic burden is strongly reduced, I can consider it for stereotactic radiotherapy. So I would like to follow the story of this patient.
Okay, so you like...
Normally, if possible, surgeons try to resect metastasis. But if it is not possible, sometimes we can treat as oligo progressive disease.
Okay, great. So nobody would consider surgery at this point in time. Palliative radiotherapy has been delivered. And as Sumit rightly pointed out, our choice was also the same. So this patient with a KRAS mutant NRAS BRAF wild was started on Folfox and Avastin. 12 doses were given over 6 months. Grade 2 neuropathy and grade 3 hypertension needing 3 drugs. So that's what happened to this particular patient that we are discussing today. So this is what was the scan at the time of diagnosis. This is November 2014. This is March 2015. So you see that there's actually a very good response in the liver. A significant proportion of the liver disease has actually shrunk. I don't know if Dr. Abhishek is again there or not. I would say, Sumit, yes, what are you thinking at this point in time?
Sir, it is, the situation looks very tempting whether to go for liver-directed therapies, whether to do RFA or microwave ablation of the lesions at this point of time, because the lesions were very, but the number was there were too many number at the beginning. So resection, I do not know, sir, but otherwise continue same.
Professor Alicio, what imaging would you do at this point in time to make your decisions regarding the liver? Would it be a triple phase MRI, or would you be happy with the CT contrast? What is it that you would do?
But if a patient did a PET scan, for me is enough to say I cannot treat this patient. It's not an oligometastatic patient.
Right. I
cannot treat all these metastases together.
I very much take your point. It's absolutely correct. There's still plenty of disease that is there in the liver, though the liver looks much better from here to here, but you can still see that there are plenty of dots, and I don't think this patient is ripe enough for any liver-directed therapy as of now. Surgery for the primary or not? So this is another question that keeps coming in the tumor boards, because there's lots of retrospective data that surgery actually improves overall survival. Sumit, would you ever subject this patient to surgery for the primary, not for the liver? Because she's responding well, there's a temptation.
If there is patient is doing well, asymptomatic for the local disease, I will continue with the systemic treatment, sir.
Great. You will continue with the systemic treatment. That is what should be the right option. Never is what I would think at this point in time, because she's doing very well on the systemic therapy. So Sumit, maintenance therapy, yes or no? If yes, what? So she is a lady who's got grade 2 neuropathy and hypertension needing 3 drugs to control the blood pressure. She's on Avastin, but yes, symptomatically, hardly any symptoms at this point in time after the palliative radiotherapy and systemic therapy. Maintenance for this patient or not? If yes, what is it that you would want to do?
Maintenance, yes, sir. Capecitabine plus minus bevacizumab after discussion with the family, sir, because she's fairly controlled, though she's requiring 3 drugs.
Okay, so good. So it's fairly under good control, requiring 3 drugs. So I'm showing you this chart to just know. So this patient's husband is such a meticulous man that every time he comes to the OPD to see me, this is the kind of chart that he would have prepared. See what's happening. FDG, PET CT scan, segment 4A lesion, 4B lesion, segment 5 lesion. So you can see how painfully meticulous he is. And at every point in time, he would get the scans reviewed by half a dozen radiologists and then come to me to say, your radiologist said this and another radiologist said that, and so on and so forth. So he was such a painfully meticulous man. Look at the way he has archived the blood reports over time. Sometimes it can be good, but sometimes it can be extremely, extremely painfully meticulous gentleman. So that's how the patient's attender was. Okay, so May 2015, surgery was deferred. Oxaliplatin was stopped due to grade 2 neuropathy and fatigue. CA was 6.21, normal organ functions. So we still put her on 5-FU leucovorin and Avastin 2 weekly. There were BP surges, but reasonably controlled. An evaluation in August 2015 showed that the CA had started going up a little bit. So this is the left lobe, the liver lesion in 17th August 2015, that's 17th August 2015. Slight increase in the amount of disease, small increase in the CA, no change in symptoms. What would you do, Sumit? Would you change therapy or just continue 5-FU leucovorin Avastin and evaluate again? Or would you do one of these choices that I have listed here?
So if the imaging wise it is stable, patient is asymptomatic, probably I will monitor the CA values and continue with 5-FU leucovorin Avastin at this point.
There is a small increase in the liver lesions, not really amounting to progression. So I very agree with your thing. So this is what happened to our patient. Patient's husband said, doctor, in 3 months, the CA value has gone up. My research says that if you use the same drug within 3 months, it's not likely to work. So let's go from oxaliplatin to irinotecan. So I tried to reason out with him and so on and so forth. But he's such a nice gentleman, you know. He's so gentle, but he's very, very firm that you cannot decline him. So after a lot of discussion and I would say argument with him, we decided to go ahead with Folfiri and Avastin. I did discuss about 3 drugs and the problems of Avastin and so on and so forth. He said, no problem, doctor. I am ready to take all the risk. He's taking the risk on behalf of his wife, not the wife. That's a different story altogether. She in fact needed a blood pressure elevation needing admission, which would be typically a situation where we would want to stop the Avastin, but that's not what we did. The Avastin was actually continued. So this is what happened. 17th August is when we started the Folfiri, and then it went on. It was 10.6, but it ended up progressing in Jan 2016, right? So progressed on Folfox Avastin, progressed on Folfiri Avastin. So here is when the next problem starts. Our husband, who has now become an expert in metastatic colorectal cancer, suggested further molecular testing. So Sumit, you are the victim now. I am in the place of the husband. NGS, we have already done mismatch repair by PCR. I told you that. Chemotherapy drug sensitivity testing. Colossal waste of money and resources, stop everything. What is it that you would choose from here? Patient is still fit, can afford anything.
So I will go with NGS. I have this thing. If you cannot argue out with the husband, sir, I have no one to do this.
You cannot argue with the husband, and hence we decided to do NGS. So the same KRAS mutation is what we found out. The same thing that we found out with 4,000 rupees, we again reconfirmed with 2.5 lakhs of rupees. There was a TP53, and then there was a CDKN2A. Obviously, you see that all of them are useless. So whenever we do something like this, our expectation out of this should be very, very tempered. One should not end up doing these tests just for the sake of doing it because it's a colossal waste of money. But at the same time, there are patients who may want to do it. So it's not wrong to do it, but please understand the implications of doing it or not. So that's the important point that I'm trying to make here. So that's what it is. So we did this and it turned out being nothing for this patient. What would you do now, Smith? Progressed on Folfox, Folfiri. Folfox Avastin, Regorafenib, Folfox Ramucirumab or Aflibercept, Folfox, none of the above, call it a day. What is it that you would do? Unfortunately, you are the only person, Sumit, so don't think I am ragging you today.
No, sir, it's okay, sir. I would, considering everything, sir, still I will try to start her on Regorafenib. I know it is not a good drug in that way, but it will still buy me some time. But other options, I will tell the husband to explore TAS-102 or
correct. So that's a good option. TAS-102 is a much better tolerated option compared to Regorafenib. So regorafenib is not a great drug, as all of us know. All that it produces is some stable disease for a period of time. It's not an easy drug to tolerate, especially in our populations. But Sumit is absolutely correct that by textbook in this situation, that should be the treatment of choice. But then this is not what happened. He said, doctor, the best treatment for my wife was the first treatment that you started. So let us do Folfox and Avastin because that is what worked so very well in her. I had to listen to him. So January 2016, CA was 40. We started Folfox and Avastin. But this is what happened. CA went up to 88 and there was further increase in the number of liver lesions. Okay, so this is what we did. So this is the increase that we are talking about. Finally, this is what happened, Sumit. There were a few lung nodules, especially in both the upper lobes. The largest was 8 centimeter. We did discuss in between about some liver-directed therapy, which I, cut it off for the sake of sticking to the time. We are already nearly half an hour with this.
I was about to add that, sir.
Thanks, Dr. Abhishek. Thanks. So that's what happened to this particular patient. So performance status was still good. Should you continue anything or call it a day? So by then, this is the number of opinions that this patient had actually taken. And I have to, clarify on every opinion that every single person everywhere was actually giving. Some said TAS, some said ramucirumab is a good option. Somebody said you put a catheter into the liver and send SIRT. All sorts of things from all over the world, including Memorial Sloan Kettering. But you know what this patient ultimately did? He started a set of these things. This is a big list of traditional fruits and foods, starting from graviola down to amla juice. So all these things the patient was consuming as she was taking treatment with me. But finally, we started discussing best supportive care, which is probably the best treatment for this patient at this point in time. Now, the reason why I'm showing you this is a hard copy of the medical reports of this patient. So the husband used to have half a dozen of this. Anywhere he went to have an opinion, he will give this book, take an opinion and come back. I put the laptop below just to show you that it was as thick as the laptop here. So that was how our patient actually was. But, patient comes in all sizes, shapes, and, mentalities, I should say. I think it's the art of medicine which helps us navigate through all of these things, not necessarily the science of medicine. I don't know how many in Bangladesh have really watched this movie called Munna by MBBS. It's a super movie. I love it because I think that's where somebody who actually does not know medicine at all becomes a great doctor, not because of his knowledge, because of the way he handled human beings and patients. So being very patient-centric in everything that you do is ultimately the most important part or one of the most important parts of our whole job. Thank you so much, Sumit. Sorry, you were the only person available, but I hope we were able to deliver some information to the audience here who've been so patient with us. Thank you so much. We'll be happy to take questions if there are any.